Hello, everyone, and welcome to today's webinar. It's all about revenue, MIPS, and primary care best practices. My name is Alex Golding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer system by default. If you prefer, just select telephone and the audio pane on the right-hand side of your screen and dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We'll collect these and, time permitting, address them during the Q&A session at the end of today's webinar. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I'd now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations, on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you to everybody for joining us today. It's going to be a pretty educational and impactful 45 minutes that we'll spend together now. And before I dive in, I want to take a little bit of a step back. We're certainly going to talk about MACRA and MIPS and what it means for healthcare and certainly for care providers. But I want to take a quick step back because we've had the elections, and obviously there's going to be a lot of changes with certain components of Congress, obviously with the administration. But then also want to talk about some regulations specifically. While there's a lot of chatter and a lot of talk and probably will be significant changes with healthcare insurance reform, there's not going to be much, if any, changes with MACRA. There'll be certainly some. So I don't say there's not going to be any, but I've actually worked with the incoming HHS Secretary, Tom Price, for probably 20 years now. And I see components that he will want to certainly shore up. I think he's a physician, and he'll want to make reporting easier and make the programs less labor-intensive and laborious for care providers and for practices and for any supporting hospitals. So I think you're going to be pleased with what he will do in that regard, but there's no one that's asking for a complete repeal of MACRA or of MIPS or of the quality payment program or of quality initiatives, or even the shift towards value-based care. And this is what MACRA and this whole MIPS program and the quality payment program was bipartisan and even bicameral. So it was both House and Senate, and both Republican and Democrats supported fixing the sustained growth rate, which is how doctors are paid, the formula in which doctors and care providers were paid, and also giving them a little bit of an increase, which started in 2016. Everybody under Medicare got a 0.5% increase, but also finding ways to pay off of quality-based reporting, outcomes-based results, and a true value-based component to healthcare. So I say all that because you're spending a good 45 minutes here today. These programs are moving forward. They're moving forward not only with the public sector or within CMS, and even components going into Medicaid. This MIPS is specifically about what Medicare is doing, but Medicaid has multiple programs around this, and all of the commercial carriers, the big payers, are all moving in this direction as well, and many have programs already today in most communities across the country. So this is, your time is going to be well invested here, and I'm going to try to dive in, and as Alex mentioned, we're going to share these slides with you, hopefully in the next 24 to 48 hours, along with a recording. Feel free to share with any of your peers. I am going to cover a lot of content. And I'm from the Northeast originally. I live in the South now, but I tend to talk fast, and I'll apologize ahead of time. I'll try to slow down, but I do like to cover a lot of ground and pass a lot of education, a lot of best practices. I promise you, if you put the effort, just a little bit of effort into MIPS, you'll be wildly successful. You certainly won't get a 4% cut, which the magazines and other publications like to glamorize, or at least talk and create all this fear. But the program is not that difficult. I've already been implementing it now for a month with our practices and our customers. So I just want to let everybody know it's not that difficult. Would love to answer any questions towards the end or even past this presentation to help everybody. But before we dive into the MIPS and the Quality Reporting Initiative, I want to take also a step to talk about where immediate revenue is going to be. And that's around business practices. That's shoring up the business activity of your organization, some of the fundamental business practices, and your revenue cycle. So I'm going to talk a little bit about that because that's where 80 to 98% of new revenue and new cash flow will come from in the next year or two is going to be shoring up your revenue cycle. So these are just fundamental business practices that I like to share with everybody. And then it also aligns very well with MIPS and any other quality payment programs that you want to embark upon or that you're going to participate in. So it all integrates together, I promise you. But I'm going to start off a little bit just from business practices around optimization, efficiencies within the practice and health system, or health systems that help practices, and economies of scale. So you want to look across your organization as well as your community to look for new revenue sources. And again, these are all, we're talking to primary care today, and primary care including OBGYN and including pediatrics. So all of that's going to be in our presentation and our discussion today. But you want to look at other new care plans or new models of care that could be distributed or offered to your community. Are there alignments with private sector companies? These are all the things that we love to work with partnership with practices around, because there could be, I know there's opportunities because I'm involved in many communities, whereas larger primary care groups or even smaller ones partner with a small business to be a sole source for at least triaging healthcare or at least non-emergency items, or large multi-specialty groups align with small to mid-sized companies to offer those types of services and be the one-stop shop for all their primary care, or even, again, large multi-specialty group for lots of different specialties. So there's lots of business opportunities and care delivery opportunities in your community, but you may have to think a little bit differently, or bringing on additional specialties or other types of partners that can really help you garner more market share in your community. Because your competition is going to come from multiple sources, certainly in primary care with all these popping up of these retail centers and urgent care centers and so forth. Lots of different polls and potentially competition in your community. So you just got to look at all of that. But then also look at aligning processes, services, and innovation to ensure that patients can easily access scheduling. There's systems that cost pennies on the dollar, but have tremendous ROI to make it easy to schedule appointments with your organization, or call strategies to make it easier to conduct business or reach your teams to make appointments. Usually when I walk out there, certainly the larger systems, their number one issue is reaching the patient. And I don't mean that through a personal health record. I meant scheduling, accessing the patient at the right time along with a staff member to take that appointment or find the right appointment. A lot of wasted time, a lot of phone calls back and forth and so forth. So, setting up scheduling, and easier access to that, picking up the phone. When you call somebody, you want someone to pick up the phone. Well, there's lots of those components that are just inherent or need to be inherent business prospects inside your practice and your hospital. Also, for appointments, make sure that your patients, for the most part, generally are being seen in the first 15 to 20 minutes. If a patient waits longer than 20 minutes or 25 minutes, they tend to feel, whether it's true or not, that the quality of their care has been diminished or is diminished, which it may not be true, but that's just a perception, and perception is reality in a lot of cases. And again, where patient satisfaction and patients are paying more, assuming more of their bill, making sure that patient understands the value, making sure they're happy, that they're satisfied, that's an important component. Spending time with them in the exam room is also important, but also making sure they're seen in a timely manner. There's lots of efficiencies that can be done in that area, but if your patients traditionally just wait a half an hour to 45 minutes to an hour or more, you certainly want to hop on that. 5 to 15% of future payments will be tied to patient satisfaction. They are today in a lot of the hospital environments. They will be under MIPS, but they are under some other programs we may participate in today. So just make sure that patients are seen in a timely manner. Also, make it easy to pay bills. You might say, well, good, Justin, of course. That's basic, simple. Well, you wouldn't believe how often practices have complicated billing processes, or don't bill on a regular basis, don't have the right follow-up, or just don't want to offer online bill pay solutions. Make it easy for a customer to give you money. And also, when I say pay bill, make sure you're collecting the copay at all instances, or at least certainly most of them, when they present. Trying to chase down $25, $35, $50, and that copay amount is growing, as all of you know. So chasing down larger amounts of money is getting more difficult. And it does not have to get in the way of the patient visit or the patient satisfaction. They expect to pay a copay when they go in. I promise you that. They just got to have that focus on the front end of your business. So those are just a couple of tenets. Now I want to talk about the revenue cycle aspect. Looking at optimizing your documentation to mitigate issues and reduce risk. So what do I mean by that? You want to look at provider workflow. You want to make sure, and we call it auditing provider workflow. You want to make sure that you have comprehensive documentation and notation. Look for under-documenting, but also make sure that you're getting paid for what you did. There's traditionally 20 to 30% more revenue in this type of an equation within a practice, depending on the size of the practice, but there's so much money that's left on the table. Assessments, questionnaires, evals, services, screening, a lot of those items are not captured, certainly not billed for. They might have been done in the exam room, but they were not captured. I promise you, every one of you can think of an example or multiple every single day where those items are being done. They're in the exam room by the provider, but they're not being captured in the notes, and they're certainly not, or they're not being billed for. And all of those items count towards your MIPS scoring. So it's very important that you make sure that you have random audits of this. We recommend, and we do for our customers, 10 per provider. You can do them monthly or bi-monthly, and you want to do them by billing and coding experts and certified coders in most cases that we do, because they find what the normal billing team may not find. And we come in there and we do re-audit, even for all the companies that we run our revenue cycle for and all the practices. We go in there and we'll re-audit every month or two or three to make sure that we're capturing everything that we need to capture and then we're fixing it so it's no longer being missed as part of the encounter and the billing. So what we also look for is missing charges. So consultation, no notes, wrong provider noted, down coding, up coding, wrong ICD-10 codes, missing modifiers. All of this, again, you're losing out on money, you're losing out on MIPS calculations, but also this will bring in additional revenue and it'll prevent rejections, it'll prevent denials, and it could prevent audits. And again, these are all good best practices that you can do by a team that might co-source with you or augment your teams or help you with billing. You want to keep the future in mind, we say. So optimize coding, and you want to make sure a lot of you, if not all of you, have invested in an EHR, an electronic health record. And you want to make sure that EHR is doing as much work for you as possible. Technology is there to assist in a lot of situations, but a lot of practices and hospitals don't optimize it, aren't capturing that documentation, not capturing those codes as part of a standard encounter. And that's just, there's so much money. Like I said, 20 to 30% revenue. When we go in and we help a practice, we guarantee 5 to 15% on a minimum of additional revenue and cash flow for that reason. Because we can go in there and just tweak and tune the electronic health record. Certainly if you're one of the leading ones in the industry, like a eClinicalWorks or a Greenway, or even an Allscripts or an Advanced, there's lots of good ones out there, Epic and Cerner, but people don't optimize them to the best for that EHR to work for them, and that's critical. Certainly at the pace that you have to keep up with these new programs, it'll be very important to make sure that EHR and all your health IT is optimized for you. You're going to hear this a couple of times throughout today's presentation. It'll help you with PQRS, MIPS, other alternative payment models that are coming out, and quality reporting initiatives. These PQRS letters are all starting to roll for people who did not file properly in 2015. They're going to get their cuts now in 2017. Now we've got to make sure we're working with a lot of practices to not only appeal some of those letters. People have come to us recently and they did not do it right back in 2015, or even the ones in 2016 now for PQRS. We're helping them make sure they get all their calculations together and they don't miss it again. So, we offer that full service to be able to make sure that you're capturing everything that you need to capture and you do your accurate reporting for PQRS. It's 2%. You can say it's only 2%, but when you look at a lot of these specialties and these practices, that's a lot of money. It's money that you just don't want to lose and you don't need to. It's very easy to do this reporting. And then certainly MIPS. MIPS is 4%. And I'm going to give you a lot of the best practices coming up on how to not get that cut. I think it's very simple. We guarantee it with our customers that you will not get that cut if you work with us. But in other alternative payment models in your community and reporting initiatives, there's a lot of money out there to go get. You want to manage credentialing, monitoring par and non-par care providers, leveraging a partner where you can. We bring in, it's traditionally, there's one on the high side. We have one hospital that we play the game with the payers. We brought an extra $9 million a year because what they were doing is the payer in New York State was actually pulling the physicians off their rolls every single month for the health system and for the payer, and then we'd go and re-credential every single month. They pulled them off the panel, and we'd play that game. It took the hospital a while to bring us in to catch it, what was going on, but we're, like I said, we'll re-credential those doctors we'll do whatever it takes to make sure that we have the healthy revenue streams going and playing the game with the payers. They're playing more games than ever before. So having a strong partner to help you with that is critically important. Optimizing collections through eligibility verifications, prior authorizations. Before you do a procedure or have an office visit, to the best of your ability, and there's a lot of abilities out there, either electronically or through manual process, make sure that you're getting those verifications, you're getting those authorizations. Afterwards, there's denials. You might get denials. You might not be able to get paid. There's so much there, and there's so much money that left on the table. There's some great best practices and strategies that can be deployed here to help. And managing fee schedules. We audit fee schedules every 6 to 12 months for our customers in most cases because we find out that around 30% of the time, the payers and what they're reimbursing for does not match the fee schedule that was agreed to early in the year in January or previous December. So you got to be looking at managing your fee schedules, looking and doing that auditing, again, every 6 to 12 months. And you can go back and collect money if they did not pay you accurately, or if we can fix something and go back and back bill, which you can do that. We've recovered millions and millions and millions of dollars this way for practices, tens of millions. So here's a couple and also denials. I'm not going to walk through the denials here. And I got a couple pages worth here to show you. These are just random examples. When we take over and we help a practice on the revenue cycle side, we come in with, say, 20 or 30 of these that are pretty standard in the industry that we can clean up pretty quickly to increase your revenue, increase your cash flow. But on the denial side, we find that only 55 to 60% of practices actually appeal denials. You should be appealing 100% of denials. We appeal 100% of the denials in every one of our practices, in every one of our hospitals. It's imperative. Again, there's so much money there, and most practices don't have a record like that. They're in the 60% range. So again, something you want to keep a close eye on. And again, all these slides will be available to you. I'm going to cover a lot of content. I'm not going to be able to cover every ounce of content in every slide, but again, that's why we're going to share all of these slides and this whole presentation with you. These are just random examples for you for primary care, and including OBGYN and including pediatrics. So now moving right along to MACRA, MIPS, and other alternative payment models. So everybody knows that the final rule was released 2014. It was bipartisan. We're not expecting any significant changes, even when Secretary Price takes over. You're going to see him probably make the program maybe a little bit easier on reporting, but that's not going to come in probably till 2018 or even 2019. So the program's set for 2017. It's starting January 1st. Again, this was bipartisan through Congress, House and Senate, Republicans and Democrats all worked together to get that bill through to help physicians stabilize their revenue. So this program is going off on January 1st. So you want to make sure you're ready for it in the next 20 days or so, 25 days. So here are the 4 options for MIPS certification, for MIPS attestation, and the options to be successful here. And again, we guarantee it. So we think the program is pretty feasible and fairly simple to not only stave off a 4% cut, but to get a 1, 2, 3, 4% increase. So option 1 allows providers and other eligible clinicians to report 1 quality measure or 1 improvement activity or either 4 or 5 advancing care information measures over 90 days to avoid a negative payment adjustment. So you only have to do 1 of these items, either 1 quality report, 1 quality measure over 90 days, 1 improvement activity over 90 days, or 4 to 5 advancing care information measures over a 45-day period to avoid a negative payment adjustment. And you can do it for longer, but that's the bare minimum. But that's very simple because that's actually easier than any program you've ever participated in. If you participated in PQRS, Meaningful Use, or any other quality reporting initiative, those are much harder than option 1. So option 1, and we set that up in practices. I already set it up, I think, 5 times last week for our practices. So it's not that difficult to get them going, and they're all going to start very early in January. Option 2 allows providers to submit a mixture of activities and measures over a minimum of 90 days. So they can do it for 90, 91, 110, 250, 270, 180, whatever it is, but you have to do it for 90 days or more, and it's a mixture of measures and activities data, and that means you can start anytime after January 1st, and you might be able to get a positive or greater, say 1, 2, 3, or even 4% increase, but you have to go for the full 365 days to get 4%. But bottom line there is just get a mixture of activities and measures, and I'm going to cover all that here in a moment, for 90 days or more. And again, you can get a 1, 2, 3% increase. That's option 2. Option 3 is you're ready to go early in January, really January 1st, January 2nd time frame. But we can also, any time in January, you can kind of get yourself all set up and report. But you can report over a 365-day period in 2017, and that will get you hopefully a full 4% increase. It might get you only 3 because there's not an exact formula here, but for the most part, if you're reporting for 365 days, you have a thoughtful plan, well laid out plan. You've certainly got a partner helping you who's been through this before. You should have a great run at least 2%, if not 3 or 4% increase. And because there's also bonus options. You're going to hear about all that. Then option 4 is participate in an advanced payment model such as a Medicare Shared Savings Track 2 or Track 3 or the CPC Plus program. There's also an oncology program. So there's lots of options for Track 4. But most people, about 75 to 85% of care providers are probably going to fall into the MIPS range. So I'm going to focus most of my comments on MIPS today. And obviously, if you have any other alternative payment models or the advanced APM questions, feel free to reach out to my team. We'll get them all answered for you, no problem. But for MIPS, payment adjustment year 1 is either minus 4% if you totally ignore the program, or again, and I'm going to go through the measures, but 1 quality measure, 1 improvement activity, or 4 to 5 ACI measures over a 90-day period, you will stave off that 4% and do it for longer than 90 days. A mixture of those measures, you can go all the way up to 4% increase. I'm going to show you all those calculations here in a moment based on your specialty. That's year 1. Year 2 is a 5% cut if you ignore the program, or up to a 5% increase in year 2. 7% cut in year 3. Again, this is all cumulative. So it starts to really add up. So right now you're at a 15% cut by year 3 from where you are today if you totally ignore this program. And then and up to a 7%. Again, this is all cumulative, so you can continue to ratchet on more. Year 3, 9% cut year 4, or up to a 9% increase in year 4. So again, all this is cumulative. So, and I'm going to talk about all those exact calculations for your specialty in a moment. But let's talk to the performance categories. So I mentioned quality. That will replace PQRS, and that will account for 60% of your total performance score in year 1. That'll be probably modified in year 2, but year 1, it's 60% of your score, and it replaces PQRS. In the second category, which is Advancing Care Information, or ACI, that replaces Medicare Meaningful Use. That'll account for 25% of your total performance score. And then the third category in 2017 is improvement activities, and that accounts for 15% of your total performance score. That fourth box we're not going to touch on because that has been pushed to 2018, and that box, the resource use, will cover or replace the value-based modifier. But we're not going to talk about that today because it's been pushed off to 2018. So I'm going to dive into all 3 of these categories now. So on the quality category, no matter what your specialty is, you'll have 6 quality measures, including 1 outcomes measure. And I'm going to talk about that in a moment, where exactly. I'm going to actually show you all of those quality measures for primary care, so you guys can see kind of the whole fell swoop of what it means for your organization. So specifically on quality, family practice, there are 55 specialty measures. For internal medicine, there are 37 specialty measures. For OBGYN, there's 24, and pediatrics, 18. Now, that shows there's a lot to choose from, but you only have to do 6. So there's no way to panic. The point there is 55, 37, 24, and 18. That just shows you the options. This program was built for your specialty. No matter what your specialty is, no matter what your workflow is in your practice, They give you a lot to choose from, but you only need to pick 6. And this is to get the full credit. Again, if you just want to stave off that 4% cut or go for maybe a 1% increase or a 2% increase, then you can do a couple of these measures. But if you want to go towards full credit, and we always recommend do more because obviously it's not that difficult, certainly to get the right partner. So, but if you want to do, you only have to do 6. You don't need to do more. There are some bonus items and all that. But for the most part, to try to get towards your 4% increase, you only have to do 6. And again, freedom of practice, that's 55 to choose from. And I'll show you all that in a moment. Now on ACI and advancing care information, that is really, that's the meaningful use type program. So option 1, if you have a 2015 certified EHR, which is a MIPS certified EHR, you have 15 measures to choose from, and you have to report 5. Or if you don't have a MIPS certified EHR, a 2015 certified EHR, then you would go for option 2. And you would have 11 measures to choose from, and only 4 are required. So just so you know, and again, if you only want to save off that 4%, you only have to do 1 of these categories. We obviously recommend that you try to do a mixture to get at least a 1, 2, 3% increase, or go for the entire program, which would be 6 quality measures, either 4 or 5 ACI measures, and up to 4 improvement activities, 2 to 4, depending upon your practice size and also the priority. That gets you the full credit. So again, if you want to go for the full 4% or even have a chance at 3 or 4%, 6 quality measures, report either 4 or 5, depending upon ACI measures, depending upon your EHR certification level, and 2 to 4 improvement activities in 2017. That gets you a 3 to 4% increase. So depending upon your Medicare volume, that could be a lot of money. And I'll show you some calculators here in a moment. So that's the 3 categories for 2017. But again, on the improvement activities, IA at the end, that's 15% of your measure, your calculation, your weight, and you'll have either 2 or 4 improvement activities, again, depending upon your practice size. If you have less than 15 participants in your practice, which many do, then you only need to do up to 2 activities, high-weighted or medium-weighted measures. You'll have 93 to choose from, and you only need to do 2 or 4. So again, lots of options, lots of flexibility here, and that's for full credit. But I think it's great. So before we dive into your specialty-specific information, some of the key takeaways: this whole program is pick your pace. Unlike meaningful use, which is all or nothing, even PQRS is all or nothing, this is pick your pace. So you can get either a stave off your 4% or go for a 1, 2, 3, or 4% increase. You still have plenty of time for whatever your option, whatever you want to do, you have plenty of time. Highly flexible. As you just heard, lots of measures available, over 200 quality measures, but 55 just for family practice. So a lot of flexibility to pick the right objectives and the right measures that fit your practice, fit your specialty, and fit your workflow. And also, as I mentioned, it's not all or nothing. You can get partial credit. You can go for bonus credits, which are easy to avoid penalties and also increase payments. So very encouraged by this pick your pace mentality that the program came out with. Also, there's a 4-point plan that I put out a little over a month ago, and it details financial success, kind of going through a lot of the revenue cycle components, but even in greater details. Clinical success, focusing on documentation, population health and care coordination, a lot of tenets to whatever program that you want to participate in or whatever quality and value-based program can be very important. Technical success means get your technology that you've already invested in, get that working harder for you. In every single case that we walk into, the EHR and the health IT that practices and hospitals have purchased, they are not optimized. They're not working hard enough for the practice and for their investment. So we get that hummed up and then cleaned up and tuned up. And also make sure staff is aligned. There's lots of revenue opportunities that staff can be kind of positioned towards that we'd love to give those some ideas. But also to make sure everyone knows that healthcare is changing. There is no turning around. We're not going back onto paper. And kind of the change management strategies is very important. But once you kind of cross that or understand that, there's so much money to be made. People, I truly believe that there's more money, and I live this every day, to be had today than there ever has been in healthcare because there's more money flooding into healthcare. But you have to be able to shift with it. You can't conduct business the way you were conducting 4 to 5 years ago. But you know what? No business in the world can conduct like they were 4 to 5 years ago and still be making the same amount of money. Everybody is going through evolutions. Healthcare is no different. So just something to keep in mind. The quality payment program, I'm going to dive now into specialty specific. So relating to family practice, I'm going to go through internal medicine, OBGYN, pediatrics, and others here right now. So regarding family practice, for all the family practitioners on the phone and practices, for the average 6 clinician family practice, it means about $14,000 year one of up to, incentives or cuts, $17,000 year 2, $25,000 year 3, and $32,000 year 4. So now when you add cumulatively, what does that mean? $32,000, $56,000 by year 3, and $89,000, $90,000 by year 4 of opportunity of cuts or positive increases to your payments, your Medicare payments. So again, depending upon the size of your practice, for an average 6 provider practice, it's a lot of money. Never mind, you add in all the revenue cycle opportunity. That's why we guarantee 5 to 15% plus. A lot of the practices that we'll go into, we'll look at the revenue per claim. They're in the 40s and 50s. They need to be in the 60s, 70s, 80s, and 90s, or higher if you go into the specialty side. So, it's easy for us to say, yeah, we'll guarantee 5, 10, 15, 20% increase in revenue because we know by streamlining and optimizing the revenue cycle and then putting them into these type programs, there's hundreds and hundreds of thousands of dollars that we can bring additional to practices. That's why we're very bullish on these types of programs and just running businesses efficiently anyhow. So here, now for family practice, I said that I would show you all of the quality measures. So here's 55 before you right now. I'm going to walk through them all. And again, I'm not going to spend a lot of time. I'm going to share all these slides with you, this content we can share. Again, you have any questions, reach out to us. We can give you the plans here. But here are all 55 measures for family practice. I'm going to walk through, again, the other specialties here in a moment. But, and again, we're not going to have time to read every single one. But here's all 55 that we package up. And when we go into a practice, we bring these with us, and we actually sit down and we looked for what measures best fit their workflow. Obviously, their specialty, but more importantly, their workflow. Again, we want to make sure we're capturing information at the right time in the documentation or on the encounter. Make sure the EHR is queued up to capture this information and that we can report on it. And also, we set up dashboards. We set up revenue cycle dashboards to make sure we're hitting all of our numbers on the revenue cycle side. And we set up these quality reporting and MIPS dashboards, or meaningful use and PQRS dashboards, to make sure that we're hitting all of these measures on a monthly basis. So when we go to report, there's no surprises. And again, I can't stay on any one slide. I'm just showing you all 55 family practice specialty measures for you. So like, you can go back one here. You have blood pressure screening and all that. You're doing all that today, which is, but you're getting, you report that one measure on patients over 18, during the reporting period. That counts. Everybody on this phone is doing that. Everybody's doing that for practice if you're a family practitioner or even internal medicine. But again, I will share all this content so you can go through the family practice ones. Now, internal medicine. So for the average seven clinician internal medicine practice, $26,000 in year 1, $32,000 year 2, $46,000 year 3, and almost $60,000 year 4. So that could be an up to that increase, or that would be your cut if you totally ignore the program. Cumulatively, that's $104,000 over 3 years and $63,000 over 4 years, $163,000 over 4 years. So a lot of money. Again, that would be cut from your practice and your reimbursement if you don't participate in the program, but also if you choose to go for the incentives, you can get those increases on top of where you are today. So again, great amount of money to go for. Now, for internal medicine, here are the 37 specialty measures for your specialty. And again, we'll share all these slides with everybody. Just want you to see everything collected in one spot. So these are all 37 measures. And you only need to do one if you want to stave off that 4% cut, or you can report up to 6 to get towards your 3 or 4% increase. So again, a lot of flexibility here based on your workflow and what your practice wants to do. But obviously, we recommend everybody kind of beginning to tackle this because there's a lot of money here at stake, and we want to make sure that you're not missing any of this opportunity. And then there's a lot of crossover measures. So again, if you look 3 down on the screen right now, preventive care and screening for high blood pressure and follow-up, patients over 18. That was also in family medicine. It's also internal medicine. So again, that one measure, we report that one measure over 90 days, that saves off your 4%. So again, would love to help you with that. But again, more so, we would have to chase down 1, 2, 3, 4% increases with you, as well as all the revenue cycle increases. Because again, there's millions of dollars, hundreds of thousands, if not millions of dollars of revenue out there additional for you. Now in OBGYN, for the average 10 clinician OBGYN practice, about $12,000. That tends to be, Medicare tends to be sometimes a lower population for some OBGYN providers. That's why it tends to be a little bit lower of a number. But $27,000 over 4 years. But cumulatively, $75,000 over 4 years of a cut, or a $75,000 increase over a 4-year period. So again, good money available. You don't want to ignore the program, but also it's not, MIPS incentives are good. You certainly don't want the cuts. But very importantly to know is every payer is moving down this direction. Most states are moving in this direction. So you can't just not participate because the insurance companies are going to pull you off the panels. You're going to lose referrals. You'll get cuts not only from Medicare but other payers. Everybody's moving in this direction. And this is not just what Medicare is doing. This one program is about what Medicare is doing. But everybody is moving in this direction in healthcare. OBGYN specifically, 24 measures to choose from. Again, you only do one to stave off the 4% cuts, or up to 6 to qualify for your, or head towards your max incentive. So again, walking through all these measures, 24 here for OBGYN. And as a reminder, we'll share all these slides with you so you can go through these at your leisure. This recording will be available to you. This slide deck will be available to you. And we do these webinars fairly frequently. We have a lot of them posted in our library today, our resource library, because we cover multiple specialties. We also do this for cardiology. We have a radiology one later on, even today. We have orthopedics. Obviously, I'm going to be covering here pediatrics in a moment as well. So, and then just general ones about the rule. So with lots of educational opportunities, we love to help in this regard. Now for pediatrics, the average 6 clinician pediatric practice, about $12,000 year 1, but up to an additional $17,000 by year 4, but cumulatively, that's $50,000 cut that an average pediatric practice would receive, or an up to $50,000 increase over 4 years if you maxed out your opportunity and went for the program. So again, great money. You don't want to leave this on the table. Now walking through the 18 pediatric measures here on the screen. Again, we'll be sharing this all out with everybody. Just want to give you a taste. Here are all 18 measures. You'll need to report 6 and just 1 to stave off over 90 days to stave off the 4% cut that everybody read about. So, and a lot of these do come across from other specialties. So a lot of these are cross-pollination. So if you've seen them one, you probably get to see them again in other specialties. Certainly, they have a large multi-specialty group. Now, outcome measures, you do have to submit a outcomes measure when applicable to your specialty. But if you happen to not to have one applicable, then you just do your 6, that out of your regular quality measures. But you really do need to focus on a quality measure, an outcomes measure, when you can, if it's applicable to your specialty. And there's 19 to choose from, just non-specialty specific outcomes measures. Because obviously we're starting to manage. 2017 is a lot about quality reporting, kind of like meaningful use was, but then they want to get towards outcomes-based reporting soon. And so you have to report at least one outcomes measure in 2017, if and when applicable to your specialty. But then when you get to 2018, these are going to start to ramp up. Again, that's why you do want to start in 2017. You don't want to wait because this program is only going to continue to step up in 2018 and 2019. So, and again, I'll be sharing all these slides with you in the next 24 to 40 hours. So now on the improvement activities, 93 total activities to choose from. You only need to do 4 medium-weighted ones or 2 high-weighted ones. However, if you have less than 15 providers in your practice, that are eligible providers in your practice, then actually you can have it reduced in half. So lots of flexibility for you. And the red H is the high priority ones. So for most practices or many practices, you can choose 4 medium-weighted ones or 2 high-weighted ones. Here, they're all going to be on your screen. I'm going to show you all 93 over the next couple of slides. And again, the red H does the high-weighted ones, and you only need to do 2 of those. And if it's not a red H, then you have to do 4 of the other ones, up to 4. But again, if you have a smaller practice, you have it all cut in half. So again, here's everything on your screen. Again, 93 to choose from, and you only need to do a mixture of 2 or 4, and depending upon your practice size. Not real difficult. And again, these are all improvement activities. Lots of flexibility. You have 93, and you've seen them all at that point to choose from. Again, 2 or 4, depending upon the size of your practice, and medium and high-weighted ones. So now ACI measures. Again, if you want to go down this reporting path, and you'll want to if you want to try to get a 1, 2, 3, or 4% increase. If you're using a 2015 certified EHR that has the MIPS certification inside it, you have to report 5 of these items. We don't have them all listed here, I don't believe, but you have 5 to choose from. You have actually 15 to choose from. You must report on 5. That's if you have a MIPS certified EHR. If you're not reporting through a MIPS certified EHR, so it's 2014 edition, then you would have 11 to choose from, and you'll have to report on 4. So that's the advancing care information required measures. So now, what will it take to succeed financially? Pay very close attention to your bottom line. Everybody's working so hard, you cannot relinquish any money that you've earned. And like I said, practices leave between 20 to 40% revenue on the table on a monthly basis, and so on an annual basis. So there's so much opportunity and now it's worth more than ever before. Practices are getting pushed. The costs have gone up 50% over the last 10 years. 50% over the last 10 years. Practices need to look for efficiencies and economies of scale and ways to improve their bottom line. And that really means optimizing their revenue cycle, which is a lot of, that revenue can be found very quickly, again, part of your daily occurrences on the revenue cycle side. So look for optimized and comprehensive coding, sending clean claims out, managing those denials, getting to the root cause of denials. And so you don't start just continuing to always have the same denials, but you want to get to the root cause and stop denials from occurring. But you want to appeal 100% of denials. Like I said, only 60% of practices appeal denials, and 60% of claims get appealed. That's just not, 100% need to be appealed. You want to, verification and eligibility, authorization management. You want to look very close to attention to payer contracts and variance rates. As I mentioned before, 30% of contracts that we look at, and this is also a good industry stat, 30% of contracts are not paid to what the fee schedule was negotiated and signed off on. So you got it, and you can go back and recoup that money. Very important to do every 6 to 12 months. And set up KPIs on the revenue cycle side, set up KPIs on the clinical side. That'll make all the difference in the world. It holds everybody accountable, and I promise you'll get hundreds of thousands of dollars, if not millions, if not tens of millions of dollars, depending upon the size of your organization, if you do that, of additional revenue. Again, I do this every single day, and it's fun. So what will it take to succeed clinically? You got to integrate data from multiple sources. And again, this can all be done very simply, because you want to be able to look at your financial aspects of your practice in health system or in clinical aspects of your practice in health system. You want to make sure that the EHR is customized for your workflow. It's tuned to capture all of that code and documentation and reports on whatever programs. Your EHR can be set up for MIPS. Your dashboards can all be set up for MIPS. They can be set up for PQRS. They can be set up for meaningful use. They can be set up for whatever you want to do. And having that expertise alongside you will help tremendously, because we can set it up in weeks, if not faster. And I do this personally at times. I did this personally with practices last week. So it all can be done, because you got to monitor it, measure it to be able to report on it. But again, that all can be satisfied. You want to implement best practices, because you want things to be repeatable. You want to have this culture throughout your organization. There's lots of best practices to ensure you're getting the revenue increases and the cash flow increases that you need, and you're successful with these programs. Best practices on the financial side, best practices on the clinical and the reporting side. Scorecarding. This is basically, we're going to look at scorecarding, again, to make sure that you're hitting all your numbers on the financial side and on your clinical side. And whatever program you want to participate in, we're going to make sure we scorecard that, so everybody knows exactly how we're achieving, where we may not be achieving, and how we can mitigate and fix that. But look at care coordination across the entire care continuum, because that's how we're going to optimize outcomes, certainly for your individual measures for 2017, but as it ramps up for 2018, 2019, 2020, 2021, and beyond. And then certainly, I always, I used to speak a lot more on patient engagement beforehand, but now focus a lot on MIPS and quality reporting programs and the QPP. But patient engagement, patient education, and patient empowerment is key to healthcare. So just make sure that you are engaging your patients, you are empowering them, you're offering them a portal or a personal health record, you're allowing them to ask for prescriptions electronically and not having to bother staff members and so forth. So again, there's so much, and educate the patient. They're yearning to learn, they want to learn, and there's more opportunities for them to engage. So just make sure you're helping in that process. And as I mentioned before, I personally believe that all care providers that intentionally and deliberately engage in new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. So I know we're at time. I want to take a couple of questions if I can, but additional resources, all four on your screen right now, the QPP website that CMS put out. You can go in there and search for your exact measures for your specialty. They don't show you the best practices that we show you, but you can certainly see what measures are available out there. iHealth, we publish all of our content and our best practices on our website. We'd love to help you in any way. The innovation.cms.gov site will show you what's happening in your community, what advanced payment models are available in your community or being successful in your community. Not all of them, but a good amount of them. So go out there and check it out. And also, Medicare Physicians Compare. Medicare is publicizing clinical data on most providers, certainly that participate in Medicare. And they're going to publish all of the MIPS results out there. So you want to go out there and understand what CMS is saying about your practice, because it's going to influence decisions that hospitals make, other providers make for you, other potential partners, and certainly patients. So with that, Alex, I'll turn it back over to you. I know that we're at time, and thank you everybody for sticking with me. Thank you.
Thank you, Justin. As you mentioned, we are at the top of the hour, so out of respect for everyone's time, we're just going to address 2 questions. So go ahead and dive right in. Our first question is, if CMS has our specialty listed for quality measures, does that mean we have to select from that list, or can we select any 6 measures?
You can select any 6 measures you want, as long as one of the 6 is an outcomes measure or high priority measure, if no outcome measures are applicable to your specialty. So you will meet the quality reporting requirements. However, the measure that you choose from for your specialty specific list or otherwise is up to you and your practice. So these are customizable all to you. You don't have to pick one. If there's not one applicable, you would have to just do 6 quality measures at that time. So.
Great. And our final question, do we need to register to participate in MIPS?
If you are participating as a group, you need to register for the web interface, or if you are using the Consumer Assessment of Healthcare Providers and Systems, that CAHPS for MIPS, you need to register. In all other instances, registration is not required. So as you get into the program, you'll understand this direction. But again, you would need to register if you're using the web interface or the other CAHPS portal system.
Thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar. It's all about revenue, MIPS, and primary care best practices. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we'll also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenter, thank you for joining us today, and have a great rest of your day.
Thanks all.